Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Well, it is inevitable for all of us. It's a difficult thing to discuss, death and dying. And it's not only difficult for patients and their families, it's difficult for healthcare providers too.
Sure. A recent article in JAMA Internal Medicine shared one physician's experience of learning how to handle those delicate conversations. The article was titled, Saving a Death When You Cannot Save a Life. I like it.
Interesting. Yep.
It's written by Mayo Clinic critical care specialist Dr. Michael Wilson. Who's in the studio with us today? Look at that. Welcome to the program, Dr. Wilson. Nice to meet you.
Thank you so much for having me. I'm delighted to be here.
Great to have you here. So I guess any physician has to be concerned at one point or another with death and dying in a patient who is going through the process. But you seem to have taken a particular interest in death and dying.
Yeah, I guess being in the ICU, it's a place where people are often on life support, and it's where oftentimes people are expectedly or unexpectedly facing their own mortality. And so for better or for worse, I get to be involved or privy to a lot of these decisions and a lot of these moments in people's lives.
Well, tell us about the story that you shared in that JAMA article.
So this was basically the story of one patient who came to the ICU and was quite sick, and she had cancer, which was blocking her intestines. And she really wanted us to do everything that we could to save her life. She was not ready to die. And so we said, well, we can potentially do a scope of your intestines, but in order to do that, we'll need to put a breathing tube in and put you off to sleep. And potentially we'll be able to find something that can fix your illness, and maybe we won't be able to fix your illness. She consented, and so we proceeded. We put her off to sleep. We put in a breathing tube and did the scope. And unfortunately, when we did the scope, we found that her intestine was basically dead, and there would be nothing that we could do to help her. Unfortunately, during that course of that procedure, she got very, very sick, and we really weren't able to safely remove the breathing tube. And so she ended up dying. She died a comfortable death, but unfortunately, she was really never able to say goodbye to her family while she was lucid. And I feel like that kind of as a healthcare system, we had stolen her last words, or that opportunity to say goodbye with her family. And so that kind of has, I don't know if it's haunted me, but it's always stuck with me. And so the purpose of this article, I learned about a technique to try to enable patients and families to be able to have this conversation of saying goodbye. And it's the process is called the going off to war talk. So the analogy is basically when two parents will have their son or daughter go off to war, they hope that their child will come home. And that's the best case scenario, is that their child will come home. But the worst case scenario is that their child may die in the midst of the war and not come home.
So how do you start that off in a medical situation?
Yeah, so you're basically saying we're in a difficult spot. We don't know if you're going to live or if you're going to die. And so in this moment, before we put in a breathing tube or potentially put you off to sleep, prior to that, we would have a conversation. While we're hoping for the best, we also need to prepare for the worst. Best case scenario is we put the breathing tube in, and your loved one will make it through this illness, and everything will be fine. Worst case scenario, these may be the last words that you have with your loved one. And so then as we prepare to put in the breathing tube, the family and the patient can take a few moments to have a conversation, to express love, to express support. And to hope for the best, but at the same time prepare for the worst.
So you're putting in a breathing tube either for some fairly complex procedure or for some surgical procedure in general?
And it could be for a procedure, or it could be because they're just really short of breath and they have respiratory failure and are needing extra support in order to keep living.
And you're hoping that at some point you'll be able to take that tube out, but you don't know that for sure.
Hopefully. And I think that this all boils down to, can we predict who's going to die, and can we predict who's going to live? And in large studies and cohorts of lots of different people, we have prediction calculators that can do that. But for individual patients, sometimes we don't know exactly how people's course is going to be. This individual patient in front of us may actually survive, or they may actually die.
Let's go back to that woman then that you wrote about. I would say, I mean, if you could project that she may not have wanted to have that conversation because she wasn't ready to die. She wanted to go ahead with this procedure. How do you think she would have responded if you would have said something like what you're describing now?
Well, I think she would have responded well to this. I've done this, maybe had 50 conversations like this since this instance with this patient, and nearly universally, patients and families welcome this idea. They like that the doctor is being upfront, that they're facing their own mortality. They like that we are acknowledging some uncertainty about the exact outcome. And I think this is a way for patients to really try to hope for the best, but again, at the same time, preparing for the worst.
You said you've done this some 50 times. Did these conversations ever get any easier for you?
I would say the wording and the word choice and the ability to help walk a patient and a family through these conversations does get easier. It's kind of like a skill of like putting in a central line or putting in a breathing tube or some procedure. The more you do, the better you get at it. But what does not change and what does not get easier is helping a human being in front of you face really difficult circumstances in a very vulnerable state.
I wonder if the patient is a medical professional, if that makes any difference. Have you had that circumstance yet?
Well, I have. I've treated several physicians and nurses and respiratory therapists and families of all of these different types of people. And I guess in summary, doctors and nurses are humans too. And when doctors and nurses are facing their own mortality, they think a little bit differently than if they're facing somebody else's mortality.
That's what I have noticed over the years working with Dr. Shives, that lots of times physicians, and articles that I've read too, want a lot less life-saving measures. They have seen what that's like for families if they're like, we're just going to keep trying, we're going to keep fighting for life. And so that's why I asked that question, if it made any difference at all.
Yeah, and I think it's very individualized. Mm-hmm. So I think physicians, especially ICU physicians, have seen where medical treatment might be quote unquote futile or not really achieve anything, that you're just prolonging the inevitable, and that causes patients and families and even healthcare professionals to suffer. But I've also seen physicians who come to the hospital as patients, and if there's a chance that they're going to be able to get through this illness, they're willing to undergo a little bit of burden, a little bit of life support, a little bit of, time to see, well, if I can make it through this, I'd be happy to go through that burden. I still want to keep living.
I think this was a really important article and something that you learned at a relatively young age. And have your colleagues who also work in the ICU pretty much signed on with this technique, followed this technique?
Yeah, it's surprisingly, it's rang true with a lot of physicians. I've received emails from physicians all throughout the entire world sharing with me their experiences of stealing a patient's last words, of doing a procedure or of treating a patient and trying to solve their issues, but not allowing them the opportunity to say goodbye. And so I don't know if it's necessarily universal, but I've received a lot of words of saying this is a good technique to try, and that they were going to try to implement this in their practice.
All right, we've been talking about the difficult but necessary conversation about death with Mayo Clinic critical care specialist, Dr. Michael Wilson. Dr. Wilson, thank you for being here.
You're welcome. Thank you so much.